Good afternoon. I'm Julie Richardson, and I am joining you all today from Louisville, Kentucky. It's a pleasure to be with all of you for the 27th annual IWMF Forum, especially so for me because 2 years ago I had no idea the IWMF existed. I was diagnosed with Waldenstrom's in March of 2020, just as the pandemic was beginning. And the folks at IWMF were a lifeline for me while I was learning all about this disease in the midst of everything else going on in the world. Research progress and drug development for Waldenstrom's has thankfully come a long way since many of us were diagnosed. Today's Ed Forum lecture is everything you want to know about BTK inhibitors. And it's my pleasure to welcome Dr. Castillo from the Dana-Farber Cancer Institute with us. Dr. Castillo will be joining us via audio today, but his slides will be visual for all of you to see as he moves us along through the information that he has. So I'm going to turn it over to that part of the program. Dr. Castillo, with our thanks. And I will see you all back here in a little bit after we hear from Dr. Castillo, and I am confident that there will be some questions to answer. Thank you so much.
Thank you. Thank you very much for the kind introduction, and thank you to the IWMF for the opportunity to talk about everything you want to know about BTK inhibitors, and you were afraid to ask. I am really going to apologize for not being able to show my face today, having a little glitch, and hopefully the audio is going through nicely, and we will talk about all these, issues about BTK inhibitors and everything you want to know about the do's and do not for this situation. So that's the first slide. The second slide, please, is going to be the disclosures, and I'm going to leave that in there for a few seconds, just for you to know that I have different, associations with different companies developing drugs for Waldenstrom's and other conditions. The next slide is biology. I'm going to start talking about the biology of the disease that will let us understand the use of BTK inhibitors. Next is going to be a slide that I presented previously on MYD88 mutations. As many of you know, these mutations are very common in patients with Waldenstrom's. In our database, as you can see in the first column on the table on the right, more than 90% of the patients with Waldenstrom's in our clinic that have been genotyped do have mutations in MYD88. There have been multiple studies from different parts of the world, including Europe, other parts of the United States, Asia. And at the bottom, proudly, I'm going to show a couple of Latin American studies now, showing the prevalence of MYD88 mutations being very high in patients with Waldenstrom's as well. In the next slide, we should see CXCR4 mutations. This is also work from the Dana-Farber Cancer Institute and the Bing Center for Waldenstrom's Research Laboratory. Dr. Zach Hunter, who has been a speaker many times for you, actually did a whole genome sequencing study in which the prevalence of these mutations was 27%. Dr. Xu developed more specialized testing, and as you can see on the fifth row from the top, our prevalence currently is about 40%. Now, CXCR4 mutations, so far I know, Waldenstrom's is the only malignancy in which we can see these mutations in the malignant cells of the patients. There are a group of kids who are born with CXCR4 mutations, but these are congenital mutations. It's a little bit different than the acquired mutations for Waldenstrom's. And these kids have a disease called WHIM, which is essentially an immunodeficiency characterized also by a decreased number of blood counts in the blood. So the reason I want to do this, and please the next slide, is just to want to show you how these conditions do interact within the cell of the malignant cells within the cells of the patients with Waldenstrom's. On the left, we have the pathway that activates when MYD88 gets activated, and the pathway on the right, which is the pathway that activates when CXCR4 is activated. So in about 2/3 of patients, the pathway on the left will be the only activated pathway for malignancy in patients with Waldenstrom's. In about 1/3 of the patients, we do have both pathways active at the same time. And in a small group of people, I would say around this time, probably about 5% of patients, they don't have mutations in MYD88 or CXCR4. And those patients have a different pathway that I am not putting in this table yet. in this figure. But the reason I'm putting this figure is for you to see that in patients in whom the mid-ADH is activated, which is over 90% of patients with Waldenstrom's, there's a specific pathway section that is led by BTK. So, and that's the reason we do inhibit BTK, because BTK is a very important component of the activation process for MYD88. And if we do, this was done in the laboratory by Dr. Trion's laboratory, if we block BTK, we're actually able to kill malignant cells in the laboratory in animal models. And for that reason, that was the rationale, scientific rationale to treat patients with Waldenström with BTK inhibitors. As you can see, the BTK pathway is not, the BTK component is not really very apparent on the right side and in the CXCR4 signaling pathway. And this really tells us that for the group of patients with mid-ADH only disease, then these treatments are extremely effective. These treatments are also effective in patients with the other pathway being activated. But as we will see a little bit later, there's a little bit of a difference between the efficacy of the treatment for these two conditions. The next slide is basically the title to start talking about the efficacy of BTK inhibitors in patients with Waldenstrom's. And I think what I can say at this time is, in terms of single agent therapy, if we take BTK inhibitors alone compared to any other treatment alone in patients with Waldenstrom's, I do believe that BTK inhibitors are indeed the most active agents for patients with Waldenstrom's at this time. The next step, the next slide is a slide that shows a table in which I am basically showing the data supporting the efficacy of BTK inhibitors in all the prospective clinical trials published to date. We do have a study of ibrutinib, which is the first BTK inhibitor that reached the market. This, as you can see, says RR. That's in patients who have relapse disease. This was 63 patients with a 91% response rate, 73% major response rates, which is an IgM decrease in about 50% or more. And more than 50% of patients had not yet progressed at the 5 years time of follow-up. Based on these data, how effective this treatment was, the FDA actually approved ibrutinib for patients with Waldenstrom's in 2015. There were 2 additional studies with ibrutinib alone. The second study was in patients who were refractory to rituximab, so were much more advanced in terms of treatment. And the second one is a TN. This is for patients who are treatment naive. These are for patients who are previously untreated. This is ibrutinib at the first treatment for the Waldenstrom's. And as you can see, the response rates are still very high, actually maybe even higher in patients who are treatment naive and receive ibrutinib as the first treatment, so progression-free survival of 76% at 4 years. Then we do have the experience with ibrutinib in combination with rituximab. This was the INNOVATE study that actually was a randomized study that compared ibrutinib rituximab versus rituximab alone. 75 patients got the combination, and again, you can see the response rate there, and the progression-free survival also very durable at 68% at 4.5 years of follow-up. And then we do have data with the 2 other newer covalent BTK inhibitors. One of them is called acalabrutinib, that is available in the United States, endorsed by the NCCN, but not yet approved by the FDA for patients with Waldenstrom's. And as you can see there, high efficacy rates, very durable progression-free survival. And the last one is zanubrutinib. Zanubrutinib is also a BTK inhibitor, very much like ibrutinib, but acalabrutinib and zanubrutinib tend to be more specific for BTK and have fewer side effects because it actually does not affect other pathways that ibrutinib does affect. And again, in terms of response rates and progression-free survivals, very effective regimens overall. Now, the beauty of these regimens of BTK inhibitors are these are oral agents. These are pills that patients take on a daily basis. Ibrutinib is 1 pill per day in most cases. Acalabrutinib is 2 pills per day, 1 in the morning, 1 in the afternoon. And zanubrutinib is 4 pills per day, either 2 in the morning, 2 in the afternoon, or 4 all at the same time. So based on all these data, as I mentioned earlier, the FDA approved ibrutinib in 2015 for Waldenstrom's. The FDA also approved ibrutinib rituximab in 2018 for Waldenstrom's, and more recently, the FDA approved zanubrutinib for patients with Waldenstrom's in 2021. The next slide. It will show our experience in the first study that was ever done. This was led by Dr. Stephen Trion from the Bing Center. And in this study, we can see how not only ibrutinib is very effective as a single agent, but really there's a difference in terms of how patients with different genomic profiles do respond to ibrutinib. In the second column, we can see the patients who have only mid-88 disease, and actually that is the patients who have the highest response rates. As you can see there, 100% response rate, 97% major response rate, and 47% very good response. Very good responses are IgM levels that are decreased at least 90%. That's how we measure response in Waldenstrom's. In the group in the middle, these are the patients with CXCR4 mutations. We have excellent responses as well, but just a little bit lower. 86% overall response rate, 68% major, and about 10% very good responses. And in the smaller group without mid-88 or CXCR4, only 5 patients were there. There were some responses, all of them were superficial. Now on the right, we can see the survival curves, and I don't know how familiar you are with all this, but what I can tell you is the higher the better. So the patients with mid-88 disease only, which is the blue line, we can see there's 5 years, about 75% chances of not yet progressing, compared to the patients with CXCR4 mutation, which is the red dashed line, in which about 4 years, 50% of patients had already progressed. And with the green line, which is the patients without mid-88 or CXCR4 mutations, within 2 years, half of these patients had already, progressed. The next slide will show us the experience in patients with ibrutinib who were treatment naive. These are in whom the ibrutinib was the first treatment. And we can see amazing responses as well, response rates as almost as 100%, with major response rates very closely to 80 and 90%. And we can see how CXCR4 in the graph in the middle, we can see how CXCR4, which is the group on the right, the very good response rates are lower, about 14%, compared to about 44% in patients without CXCR4 mutation. And as you can see on the right, again, the blue line is the patients with mid-88 only disease. Of 90% at 4 years have not yet progressed, compared to about 60% at 4 years in patients who had CXCR4 mutation. In the next slide, I'm showing some results from the Innovate study. This is the final report that just came out in January of this year. And I want to bring your attention to the graph on the left, essentially, in which the first group is the first group that had mid-88 disease only. And the response rates, as you can see, the green area is about 41% versus 23% in the second group. The first group is the patients with mid-88 without CXCR4, and the second group have CXCR4 mutations. So the depth of the response, the green area, the very good partial responses, tend to be a little lower in patients with CXCR4 mutation. The next slide will show you the curves of progression-free survival comparing ibrutinib rituximab versus rituximab alone. And again, the combination is definitely superior than rituximab alone. The downside of this study is that I would have loved to have an ibrutinib alone arm, right? Because this study shows me that if I give ibrutinib, I can make rituximab better. But it doesn't really tell me if by adding rituximab, I am actually making ibrutinib better. And there's no answer to that question at this time. We don't have a study that has compared ibrutinib rituximab versus ibrutinib alone. Suffice to say that rituximab alone seemed to be a suboptimal treatment for patients with Waldenstrom's, and about half of the patients in the study had already progressed within 20 months of therapy, while more than half of the patients were still responding well to the combination, beyond 4.5 years of therapy. The next slide is going to show you the Aspen study. The Aspen study is a study that actually compared zanubrutinib versus ibrutinib in a randomized study. Actually, this is the first study that compared 2 BTK inhibitors head-to-head in any type of disease. So this is a very important study. It's a landmark study. And in this study, the idea was to show that zanubrutinib was superior than ibrutinib in terms of very good partial responses. And as you can see on the curve on the left, at 19 months, it was a 28% difference, 28% VGPR of very good responses to Zanu versus 17% to ibrutinib. That difference was not statistically significant, And this study was labeled as a negative study initially. Despite that fact, the FDA approved zanubrutinib because of the better side effect profile, which we will see in a minute. Now, as you can see over time, the difference in terms of the response deepens for both treatments. And at 44 months, the very good responses are 36% for zanubrutinib versus 25% for ibrutinib. And as you can see on the bottom, the curves, I mean, maybe there's a bit of a benefit of zanubrutinib, just a touch, but these differences does not seem to be, statistically significant, which is an important marker for patients, for scientific data publication and understanding of how this works. So at this time, based on what I'm seeing, I cannot tell you that zanubrutinib is much more effective than ibrutinib, but as we will see later, there is a difference in terms of side effect profile. The next is a title slide saying side effects. So we want to talk about toxicity on these treatments just to make this a balanced discussion. The next slide basically is a side-by-side comparison of the different or most important side effects reported in clinical trials for ibrutinib. Those are the blue columns. For acalabrutinib, which are the red columns, and for zanubrutinib, which are the green columns. And as you can see there, neutropenia is a big one. Neutropenia is a low number of white blood cells. Tend to be maybe a little bit more pronounced with zanubrutinib than with the other two. The other ones are more decrease in platelet counts, decrease in hemoglobin attached. There's some infections. You can see infections here and there. You can see joint pains, which is a big one for all these medications. And we can see also increased liver function tests. We can see very often that as well. Maybe a little bit more with acalabrutinib. And we see atrial fibrillation. So atrial fibrillation is probably one of the most problematic side effects for hematologists because we are not cardiologists. If we were cardiologists, we would not be freaking out every time a patient develops atrial fibrillation. But now, over the years, we have been able to understand that this is a relatively common side effect. Anywhere between 5 and 10% of patients on these medications will develop atrial fibrillation. So we have become much, I would say, better at treating these conditions that are not precisely hematological. With medications that decrease the heart rate, they improve the heart rhythm, that decrease the risk of developing clots, and we have gotten much better at all that. In the next slide, which is data specifically comparing zanubrutinib versus ibrutinib in the ASPEN study, we can see how at the beginning, when it says 0 to 12 months, there were some side effects that were more pronounced with ibrutinib, specifically atrial fibrillation, bleeding, but it was more neutropenia with zanubrutinib. And if we could see almost at the right, beyond 3 years of treatment, we can see that the difference in atrial fibrillation sustains and has gotten worse a little bit with ibrutinib. Hypertension also is much higher with ibrutinib, bleeding as well, and infections, while neutropenia kind of leveled off and has evened out between ibrutinib and zanubrutinib over time. This is data that has been presented at the ASCO meeting this past July in Chicago. The next slide is actually a slide that has not much to do with Waldenstrom's, because there is no active comparisons between acalabrutinib and ibrutinib, but this is studying CLL. And CLL is chronic lymphocytic leukemia. It's another blood cancer that is very indolent, very much like Waldenstrom's. And in this report, we can also see that acalabrutinib may be associated with a bit lower rate of atrial fibrillation, as well as bleeding and infections on the right side too. So there are definitely some differences in terms of the side effect profile on these new agents, and the newer agents such as acalabrutinib and zanubrutinib seem to be associated with a lower rate of atrial fibrillation and bleeding and infections as well. To finalize that components, when talking about dose reductions, this is a study that Dr. Shayna Zaroshek from our group actually presented recently. We're actually trying to publish this paper. This is a study we put our experience together on 400 patients that we treated with ibrutinib, patients who are treated with Waldenstrom's ibrutinib. And we saw that about a quarter of these patients needed to have a dose decrease because of a side effect. On the second graph shows that the risk of those reducing or the features related with cell brosis reduction actually age over 65. Those patients tend to have those reductions, more frequently, and also women. And women tend to have a higher rate of those reductions as well. So the other two graphs actually are not projecting very well on my slide, but what I think I'm trying to show there is how some of these side effects do actually improve with those reductions. And we have seen that, I think if I'm not mistaken, probably about 2/3 of patients do actually have improvement on the side effects that prompted the dose reduction. And a very small group, very tiny group of people, actually the IgM starts creeping up after decreasing the dose. In the large majority of patients, the IgM remains stable despite the fact that we decrease the dose. Good. So just to finalize, I have a few slides left. I want to talk about the different side effects specifically that we can see with these BTK inhibitors, and then I will open the floor for questions. So the next slide will be atrial fibrillation. This is again a very common side effect, a bit more common with ibrutinib, but it's also being seen with acalabrutinib and with zanubrutinib. So for patients who are on these treatments, be aware of palpitations, heart racing, skipping beats, heart fluttering. If you have any of these issues in a recurrent manner, you need to be seen by your doctor. EKGs are great. The problem is you need to have the symptom at the time of the EKG. Otherwise, the EKG is not going to find it. And an EKG lasts maybe a couple of minutes. So if you don't have the abnormal rhythm at the time, the EKG is not going to find it. And in those situations, a cardiac monitoring is preferred, usually about a week or two. But again, if you don't have the symptoms while you're having the cardiac monitor on, then it will not be detected. So you need to be aware of that. But the cardiac monitoring for sure is preferred just because of the duration of the testing. If you are diagnosed with atrial fibrillation, you need to establish care with a cardiologist with experience, hopefully. And a couple of things can be considered. Either consider a decrease in the dose of the medication that you're on, or switch to a more specific BTK inhibitor. Or if still you're having trouble, then obviously switch to a different type of treatment. Those are essentially the ways in which we're managing this. So in our experience, at least, the patients who develop atrial fibrillation, the large majority, I would say over 90% of these patients, have decided to stay on the BTK inhibitor and have their atrial fibrillation managed with either rate control, rhythm control, and anticoagulation in some patients, given the fact that they have responded so well to the treatment. So we have managed these two conditions concurrently. So having atrial fibrillation or developing atrial fibrillation is not a total contraindication to continue on a BTK inhibitor if patients are benefiting greatly from the treatment and the atrial fibrillation is not too symptomatic or disruptive. The next slide is going to talk about hypertension. This is something that we see also very commonly with BTK inhibitors. So first thing I have to say is be aware of white coat syndrome. This is a type of syndrome in which the blood pressure just goes up because you're walking in a healthcare facility. And I would say that this happens a lot at the Dana-Farber Cancer Institute. My blood pressure goes up when I go into the Cancer Institute. So maybe it's the Boston traffic or whatever. In any case, this happens very often, the white coat syndrome, the blood pressure going up a little bit. And that's why it's important to have a blood pressure monitor at home in which you can see what is your actual baseline. The blood pressure monitoring or the blood pressure read at the Cancer Institute, at the Cancer Center, or even at doctor's office might be a little higher than the ones that you actually would experience at home when you are in a more relaxed environment. It is very difficult to distinguish the regular hypertension, meaning the hypertension that some patient is going to develop because of aging and other problems, compared to the hypertension that is because of BTK inhibitors. Sometimes we can decrease the dose and that sometimes helps, but sometimes it doesn't, or you can switch from one treatment to the next. My preference is to switch if you are having trouble controlling the blood pressure. Um, but if the blood pressure can be controlled very easily with a low dose medication, sometimes it's appropriate to continue the BTK inhibitor along with a blood pressure medication as long as it's a minor intervention. The next slide, we'll talk about gastrointestinal symptoms, and these include many of them: nausea, diarrhea, vomiting, constipation, abdominal bloating. We have a lot of that. So first of all, I think we need to evaluate for other causes for the symptoms unless there's a clear time relationship with this. What we do sometimes is we stop the medication for a few days to make, maybe 3 or 4 days, convince ourselves that there is a relation between the medication and the GI symptoms. And this is important because if you do have another reason to have diarrhea or the bloating or these other issues, then obviously decreasing the dose might not be the right thing to do. What I have asked my patients numerous times and seem to work in some of them, and again, this is just experience, this is not published data. We recommend probiotics. I mean, probiotics do help when patients get antibiotics, for example. And I can tell you that, BTK inhibitors are as powerful, if not more powerful than antibiotics, to modify your, the microbiome in your bowel. So trying probiotics for a few weeks is not an unreasonable thing to do. And obviously, if the symptoms do persist, we can always consider decreasing the dose or switching to a more specific BTK inhibitor. These symptoms tend to happen very early on, and in most patients, within 4 to 8 weeks of therapy, these symptoms do improve. But again, there's a small proportion of patients in whom they do not, and maybe at that time we can consider a decrease. If you're having some issues, over the first few weeks of therapy, might not be a bad idea to try to control the symptoms, and most of them do get better over time. The next topic will be muscle, bone, joint pains. Again, very common. We need to evaluate for other causes of body pains, and I think that's very important. We had a number of patients who presented with acute pains, and we do X-rays, and there are fractures in the bones or some other problems, or maybe trauma and things like that. So not every little bone or joint pain is because of the disease. Having said that, if you have been examined, if there have been X-rays and MRIs and all the additional testing has been done, and there's no reason for the pain, maybe it is because of the BTK inhibitor. And in that specific scenario, you can take medications. You can take Tylenol, no more than 4 grams to avoid any liver damage. You can take some NSAIDs. A lot of people feel that there's a formal contraindication of non-steroidal anti-inflammatories and BTK inhibitors, and that is not absolutely true. Having said that, as long as it's an as-needed treatments, right? If you do need it every once in a while, I think that's a reasonable thing to do. You're going to be taking, Advil or Aleve or Naproxen, 3-4 times a day for 2-3 weeks straight. I don't think that's a good idea. And that might actually give you trouble with your kidneys and trouble with blood counts and bleeding and other problems. But if you're going to take them as needed every so often, I think it's not a reasonable thing to do. This is a type of side effects that sometimes do persist in the patients, and it migrates. So it goes from the right shoulder to the left knee and then to the right hip. And, so it's not in one area specifically, it kind of migrates a little bit. But based on our experience, these also improve with dose reductions if they are too problematic. So I'm going to take a little parenthesis here. I've been mentioning dose reductions for side effects, in the last few slides. I want to make sure you understand that this is not just a pain that is a little bit of bothersome. This is severe pain. So whenever a dose reduction should be taken is for side effects that are progressive, persistent, affecting the patient's quality of life, affecting the patient's activities of the daily living. So this is not just, a little pain here or there. These are pains that are severe, or these are symptoms that are severe. Those are the ones that typically we use to guide, dose reductions. The next slide will be essentially skin, hair, nail changes. That happens a little bit more often with ibrutinib than with the other 2 BTK inhibitors, but we do see a little bit of that. Typically, these are very minor. Typically, they do not affect quality of life or activities of the daily living. So, keeping your nails short and make sure that you apply moisturizers and other things to your skin. I think that actually helps a lot in controlling these symptoms, and almost never we need to decrease the dose or change treatments because of these problems. Having said that, if there's a very large rash
that is involving, half of the body surface area or giving you severe symptoms or problem, then yeah, I think that's a good idea to switch treatments or not. But that is the minority of the cases in which these symptoms can be seen. The next one is going to be bleeding. Bruising is common, but it's not serious. You need to be aware of other drugs that can increase the risk of bleeding, like aspirin, Plavix, Lovenox, and things like that. Because of the risk of bleeding, I mean, these medications, BTK inhibitors, tend to block the function of the platelets, very much like what aspirin does. So the recommendation is to hold BTK inhibitors for surgical procedures to minimize bleeding. And it's usually a few days before, a few days after, and depending on how invasive and bloody the procedure is, then we could recommend specific durations for the hold. And whenever in doubt, talk to your doctor so we can provide you with the best recommendations to manage those symptoms. The last one I'm going to talk about is withdrawal symptoms. These happen in about 1 in 5 patients who are taking BTK inhibitors, then they stop BTK inhibitors for a few days for any reason, and they develop fevers, body ache, night sweats, chills, fatigue, and they develop it within 24 hours in most cases after the last dose. So they're missing the next dose and they're starting to having these symptoms, but the symptoms do disappear, pretty rapidly after restarting the BTK inhibitors. Interestingly enough, if you have withdrawal symptoms when you hold ibrutinib or acalabrutinib or zanubrutinib, you are always going to have the withdrawal symptoms every time you hold. If you did not have withdrawal symptoms when you held it, you are never going to have that problem. So it seems to be very specific to the person, but it's very specific to the person and then very stable within the person. We do use steroids to control the symptoms, low dose prednisone, and that can help in those scenarios to some patients as well. And finally, a couple of 2 slides. So the do's. Do take your medication daily without disruption. I think keeping a 90-95% consistency rate is really important. Do take your medication with an empty stomach or with food. I don't think right now with the new formulations that we have, there's not really a lot of issues in terms of absorption. Do check for interactions every time anybody wants to give you a new medication, either cholesterol, antibiotics, antidepressants, whatever they want to give you. Always check that there's no interactions. Do hold your medications to minimize bleeding for surgeries or trauma. So a lot of our patients are like, well, I had this surgery and I'm bleeding. Yeah, but I did not hold my ibrutinib. I don't think that's the right thing to do. Or somebody had a big trauma, in the leg or in the face or what have you, and they did not hold the ibrutinib and they are bleeding. So whenever there's any bleeding issue, stop the medication, don't take it, call your doctor. I think that's the right thing to do. Do let your doctor know about symptoms that are persistent, progressing, or affecting quality of life. I think that's key. If you have minor symptoms that here and there don't affect in your life, I don't think you need to worry much about that. But if symptoms are persistent, progressing, or affecting your activities of the daily living, I think that's when you should tell your doctors no, and things might be, looked a little bit more carefully. And to finalize, some of the don'ts. Do not reduce or stop the drug without checking with your doctor. Dose reductions, again, we're getting more data, seems to be relatively safe, but we are not reducing the dose on everybody. We're reducing the dose in the patients who are having too much side effects or too many side effects or too severe side effects in whom a dose reduction is warranted. So we are not stopping the medication because the medication is doing so great. We're stopping the medication because the medication is using a problem. So just make sure you understand that there's a very clear message. And whenever you want to stop, reduce, you have to talk to your doctor. There are people who develop disease rebounds when they stop ibrutinib all of a sudden, or acalabrutinib or zanubrutinib. So whenever you're going to do any of those things, make sure your doctor knows and there's a plan of monitoring. Do not take or eat Seville oranges, grapefruit, star fruit, or pomegranate. Those are fruits that affect how your liver function, and they can make the drug levels higher and use a bit more toxicity. Now, if you just add 1 sip of grapefruit juice, I don't think that's going to be a problem. But if you chuck down grapefruit juice on a daily basis, that's a different story. So try to avoid these products, so you don't have too many problems with the medication. Avoid fish oils, and this is not avoid fish. You can eat fish as much as you want, sushi or whatever you want. Fish oils are actually, more concentrated product, and the reason for the avoidance is because the fish oils can increase the risk of bleeding. in some patients. We had a lot of nosebleeds and and mouth bleeding in patients who were taking fish oils in our ibrutinib studies. And for that reason, I think it's better not to be on those unless there's a specific reason, but we rather avoid them. And finally, if you throw up and you vomited the dose, or you are not sure that you took the drug, do not double dose. If you are unsure, you better go 1 day without it than actually double dose, because that can actually be problematic, induce more toxicities if you take a double dose that you don't need. And with that, I really would like to complete my presentation. I really would like to thank you for your attention, and I'll be happy to answer, any questions that you. Thank you.
Thank you so much, Dr. Castillo. There are so many questions. And since you can't see those, I'm going to read them to you as best I can. And I just want to offer these 2 caveats to that. I am way new to this whole BTK inhibitor conversation. So if I mispronounce something or ask a question that you've already covered, I'll just assume that you're all going to extend some grace, you and the 372 other people who are watching. So without any more delay, here's your first question. Ibrutinib users may experience withdrawal symptoms or relapse when holding the drug. Does this happen with acalabrutinib, zanubrutinib, or pirtobrutinib?
Yeah, so obviously we do have more experience with ibrutinib because it has been around for longer. We do have also substantial experience, I would say, with acalabrutinib and zanubrutinib. Our experience with pirtobrutinib is much more limited. But in what I can tell you is, yes, we do see it with all the BTK inhibitors at this time. I think it has to do with how these BTK inhibitors do work. These are not medications that kill the malignant cells rapidly. These are type of medications that actually inactivate the malignant cells. And as you stop these medications, in some patients, we can see these IgM rebounds. In some patients, it's much more pronounced than others. In most patients, it's actually asymptomatic. But yeah, we are seeing these withdrawal symptoms as well as the IgM rebounds when the patients hold the medication in with all the different types of BTK inhibitors, covalent and non-covalent.
Okay, thank you. Next question. How does a TP3 mutation affect all of this? Does ibrutinib bypass BTK pathways so as to be effective?
Yeah, so I think you're talking about the TP53 mutation, right? That's what you said?
Yes.
Yeah.
Yes.
So TP53 is a mutation that we see maybe in about 8% of patients with Waldenstrom, so it's very rare. Classically, these mutations have been associated with resistance to chemotherapy. In other conditions, specifically in CLL, is where we have the most experience with TP53 mutation, in myeloma as well. So whenever you have that mutation, it's bad news for chemotherapy. Having said that, patients who are treated with BTK inhibitors do respond very well to TP53 mutations. I don't understand very well what they mean by bypassing MYD88. I don't think exactly that's how it works. It's just that in patients who are treated with BTK inhibitors and have TP53 mutations, these patients tend to respond very well to these medications. And in those patients specifically, my opinion is that BTK inhibitors should be probably the best therapy for those patients because they are so chemotherapy resistant.
Thank you. So I think that you touched a little bit on this next question in your presentation, but just to clarify, because it's been asked by a couple of people, do these BTK inhibitors kill the Waldenstrom cells in the bone marrow?
Yes, they do, but it takes a while, So what happens is, if you start with an IgM of 5,000, right, and then your IgM goes down to 1,000 within 2 months of treatment, you would imagine, or you would have assumed that your bone marrow disease would have gone also from 80% to 20%, right, to be kind of similar or parallel in proportion to the benefit you're seeing. But based on clinical trials, we have not seen that. The amount of disease a month later still the same as it was a month prior, even though your hemoglobin has now normalized, even though the IgM has now decreased by at least 50%, we still see a good amount of disease in the marrow. So I want to
explained that these medications, BTK inhibitors, work initially by inactivating the malignant cells. And when you inactivate the malignant cells, then the IgM production drops rapidly. And when you're inactivating the malignant cells, you're also inactivating the bad influence of the malignant cells over the good bone marrow that you have left. So these cells do reactivate, the good cells, they do reactivate. They don't have that inhibition anymore, that bad influence, and they start producing the hemoglobin the way they did before, and even with a higher levels. And that's why we see a fast hemoglobin improvement. That's how we see a fast IgM decrease. But this is not a reflection of the same proportion of cells dying in the marrow. They do die over time, and this is something that we have seen in the long-term studies. We do see that there is a decrease bone marrow burden of disease, throughout the years, but it's definitely not, as fast as the numbers would indicate. And it's because this is an inactivating agent much more than a, cell-killing agent.
Thank you. What other tests, other panels, aside from your typical CBC, perhaps, are used to monitor the side effects of these inhibitors?
Yeah, so the side effects that we see as we talked during my presentation, blood counts are important. Liver function tests are important. Very rarely we see electrolyte and kidney abnormalities. That's very rare, but we do check it every time. And I think more important than not, much more than the labs, is actually, talking to the patient, right? Talking to the patient, ask them about, how's your blood pressure, how's your heart rate, any palpitations, any infections, any bleeding problems, right? So actually, I would say I would get more information about side effects on the medications from talking to the patient than actually looking at the blood levels. But we do both, right? We should do both. We should talk to the patient and also look at the labs. But again, for labs, blood counts, kidney, liver function, IgM levels, and then ask the patients all the questions about their side effects.
Okay. So I have two questions that I'm looking at. That one is asking if the effect of one inhibitor starts to wane, can you switch to another? And then right under that is a question about someone who did change from ibrutinib to zibritinib. So I'm going to read that question about changing and then maybe lead into switching between these if you're able to. So the question is, I have recently changed my therapy from ibrutinib to zanubrutinib. Now my IgM level has decreased under the normal reference range. Are there any known reasons for that?
Yeah. So I think switching from one BTK inhibitor to another BTK inhibitor can be done for a number of reasons. I think if somebody's having a lot of side effects to one of them, they might go into the next one, and then some of these side effects will get better. We do have some data suggesting that that's actually the case. If somebody's progressing on a BTK inhibitor, let's say ibrutinib, that for me, switching at that time is a little less indicated. I'm not too comfortable, let's put it that way, making that switch without understanding a little bit better what's going on with the patient. Because most patients who become resistant to BTK inhibitors, they develop a BTK mutation. And this mutation actually renders ibrutinib, acalabrutinib, and zanubrutinib ineffective. So if the patient is progressing on ibrutinib or acalabrutinib, and they have developed this BTK mutation, then they are unlikely to respond to zanubrutinib. So in that setting, I do not change from one BTK inhibitor to another BTK inhibitor. Having said that, if somebody has a rash on ibrutinib, then I think switching to acalabrutinib is reasonable, just because acala or zanu might not have the same side effects. So in terms of intolerance, I think switching is great. But in terms of true progression, I don't think that's something that I would do. And yes, I have seen some patients deepening the response, switching from ibrutinib to zanubrutinib. It is really difficult for me to say that it's just the zanubrutinib, because we do know, based on the number of different studies, that as time goes by and you are exposed more to BTK inhibitors, your response is going to deepen. We see that based on the Aspen study. the very good partial response went from on ibrutinib went from 18% to 20% to 25%, right? So over time, the responses tend to go deeper. So was it switching to zanubrutinib that made it deeper, or it was going to get deeper anyway? And that's the part that is a little less clear. So I would recommend switching in terms of side effects. I would not recommend switching in terms of progression. If you want to deepen the response, you could consider doing it. But again, the benefit of deepening the response just to see the numbers look better without an actual clinical indication to have a deepening response, I think that situation is a little less clear in my mind.
Thank you. Okay, next question. What would be the optimal outcome of adding acalabrutinib to standard of care treatment such as bendamustine and Rituxan, as in the Brahms study currently happening in Canada?
Great. Yeah, I mean, I think the Brahms study is a very cool study. And I say it for a number of reasons. Number one is a triplet, right? 3 agents that are very effective. Number 2, it includes a BTK inhibitor that I think, obviously, as I said earlier, BTK inhibitors are probably the most effective treatments currently for this disease. But also it's a finite duration treatment. So patients are going to get 6 months of Benda-R and then 1 year of acalabrutinib. So there is some data from our laboratory and others that show that there might be some synergy between giving, when we do expose patients concurrently to BTK inhibitors, chemotherapy, and other agents. So there's actually synergy. Synergy means that we are obtaining an effect that is actually higher than the sum of the parts, right? So it's like adding 1 + 1 + 1 and actually ended up with 5 instead of 3, right? That's what synergy is all about. So I think that is what these studies are trying to look into. And for that reason, I think there is a potential benefit. I agree that maybe the toxicity might be a little higher, right, as we can understand, because we're multiplying the different agents. But maybe it will also allow to get to deeper responses that will be, more durable in these patients without the need of giving indefinite duration therapy. So I think it's a very interesting clinical trial with a number of questions that is going to be able to answer.
Thank you. Okay, are there BTK inhibitors in the making or that are already on the market that work best for people with both mutations of Waldenstrom's?
Yeah, that's a good question. So the most extensive CXCR4 testing has been with ibrutinib. And this has been part of what the research that we have been doing at the Being Center for Waldenstrom's for quite a while, almost 8 years of research. The Aspen study actually is looking into CXCR4 mutations as well for zanubrutinib. And when we looked at the data, side by side, it looks like zanubrutinib might be a little bit more effective, than ibrutinib in patients who have CXCR4 mutations. The problem with that is the studies, we're talking about smaller numbers now. The study was not designed to show that difference, right? So you can see that difference just because of random effect and not precisely because of design of the study. And also, CXCR4 mutations are more complicated because there are different types of it. And we do have some types that are more responsive to BTK inhibitors and some subtypes that are less responsive. So the distribution of the subtypes, might be different between the zanubrutinib and the ibrutinib arm. And I think we need to learn more about that to be able to provide more information. But if we take the numbers as face value, zanubrutinib may be a little bit more effective in CXCR4 mutated patients than ibrutinib. And obviously with the new BTK inhibitors like pirtobrutinib and nemtabrutinib, we don't have yet CXCR4 data to comment on.
Thank you. So this next question is from a physician in our community. What's your best advice on how many days before surgery a BTK inhibitor should be stopped due to bleeding concerns or anything else?
So that really varies on the procedure. Just to give you a few examples, for cataract surgery, we don't need to hold. For an intraarticular joint, for like an intraarticular injection, maybe a day or two should suffice. For a dental extraction, maybe 4 or 5 days. For an appendectomy, maybe 5 to 7 days, right? So it all depends on how invasive the procedure is. So I cannot tell you that there is one whole time that would apply to all the different cases.
Okay, and a little bit of a follow-up question to that, because it has to do with holding these for treatment of other things. If one needs Pavloxavid for a COVID treatment, it's this person's understanding that a BTK inhibitor needs to be held for those 5 days. So do you recommend a low steroid for that, or any other way to mitigate that?
Yeah, so there are 3 treatments for patients with COVID-19. Paxlovid is one of them. And for that, yes, it's a 5-day course. And during those 5 days, BTK inhibitors should not be taken concurrently with Paxlovid because there's toxicity or there might be toxicity. The other 2 treatments are remdesivir and the monoclonal antibodies. They are so complicated I cannot pronounce them anymore myself, actually. So those are, or those, I know, so hard to pronounce. We do not need to hold BTK inhibitors for the other 2, but for Paxlovid we do. So if a patient is well known to have withdrawal symptoms, then obviously we recommend low dose steroids to minimize those symptoms. Otherwise, just the Paxlovid alone should be fine. So basically, you take ibrutinib all the way to, let's say, Sunday, and then Monday to Friday you take the Paxlovid, and then you restart the ibrutinib on Saturday. So basically, those 5 days you just do not take the BTK inhibitor.
Thank you. I know COVID is a huge concern for this community, so I appreciate that attention to that question. Next question, is there any data yet about the progression-free survival in individuals with MD88 and CXCR4 nonsense mutation currently being treated with zanubrutinib?
Not yet. I mean, the entire group has not gotten yet to the median progression-free survival. So I don't think we have gotten there yet. The data that was published did not look too much into that, but I think there's some data coming out of ASH at the hematology meeting in December this year with a bit of that. So yeah, I will get some updates at that time, but I don't think we have a median just yet.
Okay. Could you elaborate for us on covalent versus non-covalent BTK inhibitors?
Yeah, so the covalent BTK inhibitors were the ones that were developed first. And these molecules basically bind to BTK, and they bind in a way that it stays with it. So basically the agent goes in, binds to the molecule, stays with the molecule, and it just doesn't let go. And the binds obviously are covalent binds. I mean, they do not let go, and they stay. So that interaction has to do with the specific interaction spot called 481. So developing a mutation in that specific spot, in the 481 spot, makes these medications not effective, right? That makes sense. And obviously it looks like the fact that the molecule is going always in the same spot, that's how it favors the development or acquisition of these mutations. Now, non-covalent BTK inhibitors are a little bit different. They do not bind in the same spots because the binds are a little bit different to the molecule. Those are chemical binds, but they also bind to it and then let go. It binds and then lets go. So it doesn't stay with the molecule in an irreversible manner. It's reversible up to some degree. So it doesn't create the same mutation, but as we know based on a recent paper, it might create mutations in other spots. So, and again, that's expected. Any medication that is given in a chronic manner until the patient does become resistant to the treatment is usually because of the development of a mutation that then basically makes the malignant cell resistant to the treatment. So that's I think chemically and biologically the difference between covalent and non-covalent came here.
Thank you. All right, last question. There are several people in the chat and in the Q&A who want to know what probiotics you recommend for folks who need them.
Well, it happens that in my basement I do create. No, I'm just joking. You can try any. I mean, I don't endorse a specific probiotic brand. I just whatever works. Whatever you find in your store, try it, see if it works. In some people, just trying yogurt works. Just trying these cultivated drinks that populate the bowel flora tends to work. I mean, I don't think there is a brand that I can recommend. I will not do that. I will not do that.
Thank you. But hey, how about that? An easy question for the last one. Thank you so much. Thank you for your commitment to the community.
It was my pleasure. Thank you for the invite. It's always, I'm sorry that I cannot, show my face today. Next time I'll be better prepared. But I hope if this has been informative to you, and I really wish you a very nice rest of the day.
Thank you. We appreciate it, Dr. Castillo. Thanks.
Take care.